This presentation reviews ventriculoperitoneal shunting for hydrocephalus in adults living with HIV, using the systematic review and meta-analysis by Lone and colleagues, published in BMC Neurology in 2020. The clinical problem is a difficult one. Hydrocephalus in advanced HIV often occurs during serious central nervous system opportunistic infection, especially cryptococcal meningitis or tuberculous meningitis. In that setting, cerebrospinal fluid pressure may be life-threatening and potentially treatable, but the patient may also be medically fragile, immunosuppressed, and at higher risk of poor outcome. The review included 9 observational studies and 124 HIV-infected adults who underwent ventriculoperitoneal shunt insertion. The review shows that the evidence is small, heterogeneous, and uncertain, while also suggesting that outcomes differ meaningfully by infection type and by baseline clinical status. The core question is whether hydrocephalus in an HIV-infected adult is a reversible pressure problem, a marker of overwhelming infection, or both. In routine hydrocephalus practice, a shunt can be a durable way to control cerebrospinal fluid pressure. But in HIV-associated opportunistic infection, the decision is less straightforward. Tuberculous meningitis and cryptococcal meningitis can both raise intracranial pressure, yet their mechanisms, expected course, and response to temporizing measures can differ. The surgeon and treating team must decide whether the patient's deterioration is attributable to pressure that a shunt can relieve, or to severe meningitis, infarction, immune compromise, or systemic illness that a shunt cannot fix. Lone and colleagues asks what are survival and functional outcomes, shunt complications, and prognostic indicators after ventriculoperitoneal shunting in HIV-infected adults. The pathophysiology shapes the decision to operate. In cryptococcal meningitis, the common issue is impaired cerebrospinal fluid resorption and raised opening pressure. Patients may improve with antifungal therapy and repeated therapeutic lumbar puncture, and some cases of communicating hydrocephalus may settle as the infection is controlled. In tuberculous meningitis, basal exudates and inflammation can impair resorption, but they can also obstruct ventricular outflow and cause non-communicating hydrocephalus. Tuberculous meningitis also brings additional injury from vasculitis, infarction, and inflammatory damage at the base of the brain. So a scan showing large ventricles is not enough. The treating team must confirm true hydrocephalus with raised pressure, distinguish it from hydrocephalus ex vacuo, and consider whether temporary drainage, antimicrobial treatment, antiretroviral therapy status, and neurological grade point toward a recoverable pressure syndrome. The authors set out to identify all published studies of survival and outcome in HIV-infected adults who underwent ventriculoperitoneal shunt insertion. Their protocol was registered in Prospero, and the outcomes were mortality at 1, 6, and 12 months, functional outcome, shunt survival, infection, malfunction, or other perioperative complications, and baseline predictors of outcome. This is important because a survival number alone does not answer the question families and clinicians face at the bedside. A patient may survive but remain severely disabled. A shunt may initially work but later become infected or obstructed, and a high mortality rate may reflect the severity of disease rather than harm caused by the operation. The authors also stated in advance that the evidence base would probably be too limited for broad meta-analysis, which turned out to be correct. Methodologically, this was a broad search applied to a narrow and difficult evidence base. The authors searched 10 databases and registries without language or date restrictions, with the last search update in October 2019. Eligible studies included HIV-infected patients age 16 or older who underwent ventriculoperitoneal shunting for any indication and reported survival or clinical outcome. Screening was performed independently, and risk of bias was assessed using a domain-based quality tool, with evidence certainty summarized through grade. The plan was to use meta-analysis only where studies were sufficiently comparable. That restraint matters. In rare high-acuity surgical questions, it is tempting to combine whatever numbers exist. Here, the authors recognize that a pooled estimate can look precise while still being clinically fragile if the underlying studies are small, selected, and unevenly reported. The Prisma flow diagram gives the first major result. From 793 records, the authors screened 723 unique records, 33 full-text records were assessed, and only 9 studies met inclusion criteria. Of those, just 2 could contribute to the quantitative comparison of 1-month mortality in tuberculous meningitis. This is the central limitation of the review. The question is common enough to matter clinically, especially in settings with high HIV and tuberculosis burden, but the published evidence is thin. The 9 included studies were all observational. Several were small case series, Some came from the pre-antiretroviral therapy era, and many had incomplete reporting of baseline severity, follow-up, shunt complications, and function. The included evidence was almost entirely about two infections, cryptococcal meningitis and tuberculous meningitis. 6 studies reported 49 patients with cryptococcal meningitis, and 3 studies reported 75 patients with tuberculous meningitis. That distribution is clinically plausible because both infections are major causes of raised intracranial pressure and hydrocephalus in advanced HIV. But it also means the review tells us little about other possible causes, such as lymphoma, bacterial meningitis, coccidioidal meningitis, or unrelated hydrocephalus in a person who happens to be HIV positive. The studies also differed in country, era, antiretroviral therapy availability, criteria for shunting, and outcome reporting. This is why the authors did not compare cryptococcal and tuberculous meningitis directly through meta-analysis. For cryptococcal meningitis, the review found descriptive survival outcomes that may sound relatively reassuring at first glance. Among studies reporting 1-month follow-up, 17 of 21 patients survived, or about 81%. At 12 months, 20 of 29 patients with follow-up survived, or about 69%, but the interpretation has to be cautious. These were small, uncontrolled studies, and the authors graded the evidence as very low certainty. Functional outcome was essentially absent. No study reported a validated functional outcome measure at any time point. Shunt failure and complications were also inconsistently described. One study reported shunt obstruction, another described shunt infection and an overdrainage subdural hematoma, but timing was unclear. So for cryptococcal meningitis, the best message is that permanent diversion may help selected patients, but the evidence does not reliably quantify benefit, function, or shunt risk. The tuberculous meningitis data are more sobering. Across 3 studies, reported 1-month survival after ventriculoperitoneal shunting ranged from about 33% to 62%, with a cautious pooled descriptive estimate of 51.5%. Functional outcome was limited as well. 2 studies reported Glasgow outcome score at 1 month, and the pooled estimate of good outcome was about 42.2%. Longer-term estimates were weaker because fewer studies reported later follow-up, and key outcomes were missing. No tuberculous meningitis study reported shunt survival, shunt failure rates, operative complication rates, or AIDS-specific mortality in a way that could guide decision-making. This matters because in tuberculous meningitis, hydrocephalus may be only one part of the injury. Vasculitis, infarction, severe basal inflammation, advanced HIV, anemia, and untreated infection may all influence survival independent of the shunt. The only true meta-analysis in the review examined 1-month mortality after shunting in tuberculous meningitis, comparing HIV-infected patients with HIV-uninfected controls. 2 controlled studies contributed. The pooled odds ratio for 1-month mortality in the HIV-infected group was 3.03, with a 95% confidence interval from 1.13 to 8.12, and a p-value of 0.03. Statistical heterogeneity was reported as 0%. It appears that HIV infection was associated with higher short-term mortality after shunting for tuberculous meningitis. But the clinical caveat is essential. Only 2 studies contributed, matching was imperfect, and one comparison involved mostly adult HIV-infected patients against mostly pediatric HIV-negative controls. So the finding should influence counseling, but it should not be treated as a definitive causal estimate. The critical appraisal heart of this paper is certainty of evidence. Across outcomes, the evidence was low to very low quality. The reasons are familiar: small observational designs, selection bias in who was offered surgery, incomplete baseline data, loss to follow-up, inconsistent outcome definitions, and sparse reporting of shunt-specific complications. Several studies also came from before widespread antiretroviral therapy, which limits applicability to contemporary practice. This means the pooled numbers should be used as rough counseling anchors. It also means we must avoid a common interpretive mistake. Poor outcomes after shunting do not prove that shunting caused poor outcomes. Patients selected for shunting often had severe hydrocephalus and severe infection. Without comparable non-operative cohorts, the review cannot fully separate prognosis from treatment effect. Clinically, the review supports individualized, multidisciplinary decision-making. Reasons to proceed might include true radiological hydrocephalus with raised pressure, neurological decline plausibly attributable to cerebrospinal fluid pressure, non-communicating hydrocephalus, failure of serial lumbar puncture or temporary drainage, and a treatable infection with access to appropriate antimicrobial and antiretroviral therapy. Reasons for caution include poor neurological grade, cerebral infarcts, severe systemic illness, very low physiologic reserve, uncontrolled infection, very abnormal cerebrospinal fluid parameters, or inability to monitor shunt complications after discharge. Hydrocephalus ex vacuo should not be treated with a shunt. The practical question is cerebrospinal fluid diversion likely to change the trajectory, and can the patient survive long enough and recover enough to benefits? A pragmatic pathway starts with diagnosis. First, confirm true hydrocephalus and raised pressure, rather than atrophy-related ventricular enlargement. Second, define the infection and begin appropriate treatment, antituberculous therapy for tuberculous meningitis, antifungal therapy for cryptococcal meningitis, and antiretroviral therapy planning in coordination with infectious diseases. Third, assess whether temporizing measures help, such as serial lumbar puncture, lumbar drainage, or external ventricular drainage when appropriate. Fourth, risk stratify using neurological grade Glasgow Coma Score or Glasgow Outcome Score where available imaging evidence of infarction, CD4 count, hemoglobin, cerebrospinal fluid cell count, protein, glucose, microbiology, and opening pressure. Finally, decide whether the expected benefit of permanent diversion outweighs operative and shunt-related risk. The key is to make the decision explicit, documented, and revisable as the patient's trajectory becomes clearer. The study had a registered protocol, a comprehensive search strategy, clear eligibility criteria, duplicate screening, formal risk of bias assessment, and appropriate restraint about when not to meta-analyze. The weaknesses are mostly weaknesses of the available literature rather than of the review itself. The studies were small, heterogeneous, mostly uncontrolled, and unevenly reported. ERA effects are substantial because antiretroviral therapy access changed over time. The review also cannot resolve confounding by indication. The sickest patients may have been selected for shunting, while others may have died before referral or been managed medically. For teaching and practice, the best use of this paper is to support careful counseling with explicit uncertainty. It justifies saying, we have a plausible intervention but weak evidence. We need to weigh pressure relief against disease severity, infection control, and realistic functional recovery. The take-home message is that ventriculoperitoneal shunting in HIV-associated hydrocephalus remains an evidence-limited decision. The current literature is inadequate to reliably determine the risks and benefits of shunting in HIV-infected adults. Reported outcomes appear worse in HIV-associated tuberculous meningitis than in cryptococcal meningitis, but the comparison is uncertain because the studies differ in design, era, and reporting. In the only pooled analysis, HIV infection was associated with higher one-month mortality after shunting for tuberculous meningitis, with an odds ratio of 3.03. For practice, the review supports selective shunting after confirming true hydrocephalus, assessing whether pressure is driving deterioration, optimizing infection treatment, considering antiretroviral therapy status and systemic reserve, and planning follow-up. For research, the urgent need is a prospective, population-based cohort collecting standardized clinical, radiological, microbiological, surgical, survival, functional, and shunt-specific outcomes.